I want to tell this thing to everyone that of course, if I had some financial interest, maybe I will doing it in even a better way, because I have to sell my product sort of thing. So number one thing is that I have no financial interest, because some people message me, how much are the charges, and etc etc etc. Okay, even I put it on YouTube. I have to clarify one thing, that YouTube is for easy access, number one. And number two, even if, for example, if I earn something, let me tell you, just again, I am just sharing with you that sometimes things are not as they look like. Last year, actually, I got the subscription for one of the articles which I have arranged. I'm sure not majority of people look at it, because majority people are still in love with books. But in 2022, I think that if you just keep all the books like a holy books and put it on top of cupboard where you don't reach them, I think you will have a better concept. Okay. So I took last year subscription of one of the journal, and it was costing around 1000 in real, and I think $250 dollars. Okay, so I'm just sharing with you that even I have no idea how to get any money from YouTube. I have heard that people earn a lot. Even in one of the gatherings, some of the people were saying that now you have put it monetization, so how much are you earning? So that's why I just took few seconds to let you know, all of you. So if you want to spread this message to everyone, I will be thankful to you, whosoever knows me and whosoever. So number one, don't have any financial interest. Number one. Number two, I don't want to feed you like a baby. I don't want to teach you like a 5 grade candidate. Sometimes you will see that I am telling you only, I just want to guide you, because all of you are grown up. You have passed through medical college, and then after that you are doing post graduation. So you know everything. You just have to align yourself. The people who are appearing in the oral part only have to align, and thus just have to tune. That's what you want, you need. This is another thing. And the people who are doing the residency, unfortunately, in our part of the world, because we are a developing country in Pakistan, you will be surprised. The people who are in Pakistan must be thinking that it is the worst. Okay, but I have encountered people working in African countries with whom I encountered when I was doing a European diploma classes in Dubai. So actually, for the first time, I came to know that there is something even more compromised than us. Okay, so I realized that we should only be thinking. We are only thinking about ourselves. We are not thinking about others. So this is a message, because maybe one of you is from African country, so maybe that I would like that person to speak out. I think this colleague got in. I'm not sure, because I have some people in the group who are from African countries. So they are, believe me, you will be surprised that they are so deprived. They don't have any facility. They are earning nothing, but they are surviving. Okay. So this is another thing. But what I wanted to tell you, that residents, they are not guided properly. Okay. That's why they suffer the whole of their career. They are in habit in the wrong side. They are trying to do the post graduation like grade 9 or 10 or even medical profession. So it is not medical college. Here you have to tune your brain, and in the exam, if you are in a tunnel vision of a book, you will suffer. So that's what I want all of you to know. So all of you who have not subscribed the channel, I will request you, because I feel embarrassed to ask this thing, because some people will thinking that I have some financial interest. So even if I earn something, I will do something good for you people. Okay, so that's my message. And that's a commitment to myself. Right now, why I got late, I was stuck in traffic. So I got late. So I just try, despite all the problems around me, family, kids, job, I just try to continue it. And why I'm speaking out, it is only to invite you people to help me out. Okay. Because the people who pass the exam never come. Very few people who pass the exam come to help me out. Only, for example, if I'm busy, I would like this thing to continue. I just recently, 1 week ago, 10 days ago, I'm just sharing. I'm sorry that I'm taking, but actually because I was so frustrated, that very few people come, very few people listen, very few people spread this message. Okay, 10 days ago I had a baby boy. Okay, after 12 years, my last son was 12 years ago. Okay, so I have another baby after 12 years, and I took a class even when my wife was in the hospital, and there was a CTG sound behind it. Okay, so that's, I'm not saying that I'm getting any reward out of it, and I don't want any personal projection, because I'm not in a teaching setup. I'm in a simple hospital in Saudi Arabia. So this is what I my passion is. So I would invite all of you to join me. This is not for anything personal for you. Even maybe you will be thinking what benefit you will get, but I think if I think that what benefit I will get, believe me, I know all these things, and only I am doing it just to help my cause of my specialty, because people don't respect anesthetist. They think that anesthetists are just extra. Okay, so this I will tell you that I'm doing it for this thing. When during my training I was a lot deficient, and I learned very late. Okay, so I have passed through failures and failures. So that's my passion is. So I will, anyone who is listening to my this 3 minutes talk, I will request, please help me out in whatever way you can. Okay, and even helping me is that you join my hands, just share anything, just talk to me. I am always available to everyone without borders. Okay, so thank you very much for listening to my emotional talk. Now we will start what we have started. Actually, the shop which we have started this now is a very complicated subject. It looks very simple, but it is actually in the exam. No exam is fulfilled without it. Okay, so this is a question which is asked multiple times, but still you can be stuck, because I came to know, if I ask you what is difference between laryngospasm and bronchospasm? Yes, please. What is difference between laryngospasm and bronchospasm?
So laryngospasm is the spasm which will cause occlusion or blockage of the larynx, and bronchospasm is the constriction of bronchioles, bronchi.
So
Yes,
actually one
lower
is upper
respiratory
airway,
area.
one is upper airway obstruction, and the second is lower airway obstruction.
One,
okay, both can cause hypoxia. Okay, in the laryngospasm, the sound which is coming is usually, what is that sound?
Strider.
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 Okay, and if you have bronchospasm, what is the name of that sound?
Wheeze.
Wheeze is
or rhonchi.
Wheeze or rhonchi.
Rhonchi.
Okay, so what is difference between wheeze and rhonchi?
Wheeze is audible without a stethoscope.
Okay, so this is something some people, because I was surprised to know that one of the resident was failed because he was not able to pick the difference between laryngospasm and bronchospasm. Okay, so that's why I wanted to tell you. The end result is hypoxia. Okay, so hypoxia is evident in the form of low SpO2, or clinically patient will be looking like cyanosed or bluish. Okay, and in some people, this hypoxia will become even like, maybe hypoxia is not picked even before cardiac arrest, especially in pediatrics. Okay, because sometimes there is some hypoxia going on, and the result is in pediatric patient maybe a cardiac arrest. Okay, so how to have a differential diagnosis of hypoxia in operation theater with GA? So if you see that saturation is going down, how you should approach?
We have to do the dope test.
What's that?
Disconnection, oxygenation, positioning, and
okay. As an examiner, if you will tell me
Equipment
this,
failure.
remember one thing, this is for your remembrance. Okay. I will never be happy if you will start your answer for hypoxia in this way. This is, I don't think so. It looks very attractive. The same approach, call for help. 100% oxygen.
Yes, call for help.
100% oxygen. Okay. And clinically core, and you will take it on, if the patient will be on ventilator, so you will take it on manual. And you will see the compliance. You will see the chest rise. Okay. And that time you are doing the dope test. I'm not saying that you said something wrong. Okay. But if you start your answer with dope test, believe me, examiner will not be very happy. Okay. Is it written in some book or is it a mnemonic, online mnemonic?
It's a mnemonic, sir.
Yes.
Used by our professors actually.
Remember one thing.
Used by CPS.
Unless this examiner himself is there, and I will never suggest you to start like that. If you remember, you were starting your answer the other day again with pads, and I stopped you. Okay, so I will again twist your ears for that answer. This is not a correct answer. I'm not saying this is not a wrong answer, but it is not a good answer. Okay. Trust your knowledge, trust your approach. If you have this approach, nobody can say anything. Okay. So you check the compliance, you are feeling increased airway resistance. Okay. Because now a lot of things will be whether this is supraglottic or LMA gel or ETT. Okay. So if it is ETT, you will be looking at whether it is blocked or endobronchial.
Blocked, endobronchial.
This one K blocked, maybe because
disconnected,
of kinking or secretions or disconnection. Okay. So and if it is endobronchial, you were combining it with the chest rise. Okay. So if it is that problem, so if it is endobronchial, so chest rise will be one-sided. So you are doing the auscultation. Okay. So you will be doing the auscultation and you will be finding the reasons. Okay. If it is LMA or IGEL, you should be, in addition to whatever you are trying to do, try to listen to the leak. Okay. If there is leak, most probably it is dislodged, because I more so with LMA and also with IGEL patient, there may be it may be dislodged and you need to reposition. Another reason at that time, immediately at the same time, you will be seeing at the level of anesthesia. Okay. Whether patient has inadequate, and inadequate anesthesia will be evident more with LMA IGEL. Okay. Rather than with endotracheal tube, because already you have limitation of what pressure. You would not like to raise the pressure more than 50 to 20 millimeter of mercury. Okay. So if it is going beyond that and patient is fighting, there is stacking, so there will be problem. Okay. At the same time, when you are doing this compliance test, or you are doing the compliance and chest rise, you will be ruling out circuit disconnection. Okay. And if you correlate with end-tidal CO2, you might find some stuck, like any problem in the circuit. There may be problem with the, what are the components over there? You maybe have soda lime issue. Okay. Maybe you have this inspiratory valve issue. Okay. Or expiratory,
leakage in the system.
Leakage in the system. Okay. And at the same time, the other things what monitoring you are looking simultaneously is SpO2, okay, and tidal CO2, heart rate, blood pressure. These are all giving you some sort of information. Okay, they are all giving you information. Then another thing, because for example, again, we discussed before that if there is decreased blood pressure with hypoxia, the reason may be a little different. Okay. So you will be looking at something serious. Or another thing is that now you will be looking at the agent analyzer. Okay. And agent analyzer is showing you FiO2. What they show? End-tidal oxygen. Okay. And the agent concentration, the MAC. Okay. So they are telling you a lot of things. For example, if like there is some problem with the oxygen supply. Okay. So if there is some oxygen supply, so if, for example, if you concentrate here, what may be the problems related to oxygen supply? So what will be those?
Sir, incorrect. I mean, hypoxic mixture could be delivered to the patient.
Okay.
Oxygen supply could be connected.
Okay. So usually there is
flow
one
meter,
cylinder supply and one
central
is
supply.
central
Supply.
Okay. So there is a cylinder supply which is high pressure and central supply is 4 bar. Okay. And then there are pressure reducing valve, which are at the end of the day, they are having, both of them are at 1 bar. Okay. This is one thing. And then at, for example, if the problem with the this oxygen supply, so there will be something which is not related to electric supply, and it is not related to any, it is something different. What is that one? Which will be there in every machine, even in Africa or in India or in America. What is that thing?
Sir, the oxygen supply works without any kind of electricity.
So there is something which will be making noise. It's a?
Yes, sir.
Ritchie?
It's a whistle.
Ritchie whistle.
Whistle, yes.
Okay. It has, it is there common any part of the world. Ritchie whistle will be sounding. Okay. So if, for example, maybe there is no FiO2 indicator or end-tidal oxygen indicator, even then it will be there. Even if there is no oxygen analyzer, this is something in any machine. Ritchie whistle is there. I don't think so. Yes. Any machine which is without Ritchie whistle. Usually every machine in the world now will be having Ritchie whistle. Okay. So this is one thing which will be there. Then maybe the cylinder is finished. Okay. Maybe central supply pressure is decreased. Okay. So immediately, in addition to whatever you are doing, if there is Ritchie whistle is whistling, what you should be doing at the first? You should be looking for what thing? The savior is ambu bag.
Yes, sir. Ambu bag, and then the.
Of course, I'm not saying that you will not be doing anything else, but the thing which will never fail you is ambu bag. Okay. Because if, for example, supply is getting decreased and you are not able to find the solution, the next step will be ambu bag. And even, for example, if you don't have ambu bag, in emergency scenario, you have nothing. What is another resort you can do if you have endotracheal tube? You will just start using like a shisha, smoke.
Yes. Like a fake.
Yes. Okay. You will just try to balloon the lungs with your mouth, and there will be around 16 to 17% of oxygen which you can give. Okay, by this way. If you have everything is failed, this is our sort of mouth-to-mouth ventilation, and actually I have the honors of doing this once in my life. I have done this thing once in my career, way back around 14 years ago. I have done this thing. In the meantime, because anyways, so this is something interesting. So what else will you do? Then now we coming back to other oxygen safety system. Just it is not exactly part of it. Just to revise, what are the oxygen safety system in the machines? Of course, if you are talking about the modern electronic machine, things will be different. But in the traditional rotometer machine, what will be there? What are the safety features for oxygen?
Pin index, sir.
Pin index system.
This is a backup cylinder.
Let her speak. The pin index system, diameter index.
The color
PIS and DIS. PIS for cylinders. Okay.
And this for diameter.
And then
the knob. Central supply.
This is a tug test. You will see whether
Tug test.
Okay, tug test. And
Hmm.
then if you come to there are pressure reducing valves.
Valve, yes.
Okay.
Specific knobs on the flow meter.
Okay, so if you just now come to rotameter. So what are things in rotameter?
There's specific color, universal.
Color.
And specific touch features that if light goes, you
bigger,
can touch and detect it.
Bigger, oxygen is bigger. Okay, color bigger.
Yes.
And usually on the downstream. Why it is downstream? What do you mean by downstream?
So downstream means that it is placed in the end. Like there are 3 or 4 gases coming in the machine. The oxygen will be in the last. So that even if the
okay, for
other
example,
gases are
if
coming,
oxygen
will.
For example, if it is, for example, these are the entering things. If, for example, oxygen were here, okay, and it is disconnected, so these gases will go, okay. So the concept is that the oxygen should be here at the last.
Yes.
If the direction is toward this direction, so oxygen will be coming at the end, okay. And this one, so if, for example, if oxygen is disconnected, no gas will be flowing, okay. So there are some other features here with the rotameter are minimum flow, okay. Minimum flow, even if you forget to open the flow meter, at least 200 to 300 ml will be going. When you switch on the machine, at least 200 to 300 ml will be there, even if you forget to open it. Then there is interconnecting system. What you say, the exact name of this one, that, for example, it is with the basic safety around 1:4 ratio. It is there, like oxygen and nitrous oxide or air, if it is going, it will not let less than 25%. Okay. So if you are trying to reduce the oxygen, nitrous will also reduce, and even at least air will be started going. Okay. So this is actually a safety feature. Okay. There is exact name which I forget. What is exact name? You should be knowing it. What is the exact name of this system?
Fail safe.
Yes. No, not fail safe. Fail safe is something else. Fail safe is something else. There is interconnecting something like that. Okay. You just, you can recall it. I'm just trying to revise it for you. Okay. So like there will be some features in the rotameter, and even if oxygen is failed, even if you forget to switch on the rotameter, there is interconnecting system, so oxygen will be going. So these are just a revision. Actually, it's not, you don't need to tell it when you are discussing about hypoxia, but you should be knowing what are the safety features are there. Okay, so what about oxygen flush? Oxygen flush is also to there if there is a leak at the level of when you are doing mask ventilation and you are having a leak. Okay, so oxygen flush is actually also a help. Okay, usually how much oxygen is going when you are pressing the flush button?
30 to 40.
35 liter.
Okay, and what is the difference in the pressure? Usually
Pressure
we say
is
that it
same
is
as
going
the.
at 1 bar. Sorry, but as same as?
No, sir. Not 1 bar. It's the highest pressure.
No. Say 1 bar is the pressure which you are usually giving at the Y
Yes.
connector. Okay. So how much pressure is in the oxygen flush?
So it's around 45, 50
45, 50 what?
bar. Millimeter of mercury.
No, please try to make it your like simple. It's not this one. This is wrong. You are using, and this is basic. That's why I'm asking you. This is 4 bar. Okay. And actually it's the same pressure which is coming from the central supply. Okay. So this is the 4 bar pressure which the patient will be receiving when you are pressing the oxygen flush. Just for additional information, that there is another place where you need 4 bar pressure. Another part in the anesthesia workstation which is receiving 4 bar. That
Ventilator.
is ventilator. Okay. Because ventilator bellow, they have from the outer side, they will have more pressure. That's why that will be the pressure which will be pressing the bellows. Okay. So this is something which you should be knowing. And another sort of safety feature in machines is APL valve. Okay. And the ventilator shut valve. What you say, there is another name, pop-up valve, something. Okay. So it is to avoid pressure changes. Even if you are pressing oxygen flush, don't worry, it will not be delivered to the patient. Okay, because the extra the gas will be pumping out. It is just filling it. It is just to fill the gap. So there is a lot of confusion among the people that if you, of course, if you are pressing it forever, of course there will be problem. But if you are doing it for periodically, just to help yourself, okay, there will be no problem, because these things will be shunting it out. Okay. So these are some of the oxygen safety features, and just very simple how to confirm the endotracheal tube position. It's a very basic question, but you
Tidal.
should. And tidal is one of them. What else?
Direct laryngoscopy.
Fogging of the fogging of the ETT.
Fogging of ETT. What else?
Chest rise of the patient.
There is a calorimetry method. There is a color change calorimetric thing which they do in emergency. Okay, usually being done by the non-technical people, clinical, and then
chest rise. Clinical
chest rise. This was I was writing just X-ray, and if you are now in this era, ultrasound. Okay, you can confirm the endotracheal position by these things. So these will be the things where in any part of your management, if it is the reason, you will be looking at it. So just to recap what we were trying to see, that there may be some physical problem. Okay. And yeah, the supply is the problem. Okay. So, and then endotracheal tube is a problem. We are not entering in the lungs at the moment. Okay. We are just above it. So if tube is not in the right position, tube is kinked, tube is blocked, or can there be a similar, because Ishan, you will not answer, you know it, because I have told you many times. Is there any picture like laryngospasm while the patient is intubated? Is it possible? And resulting in this negative pressure pulmonary edema? Can this occur when the endotracheal tube is there? Because when you are having endotracheal tube, you bypass the larynx. So how can laryngospasm occur? But a similar feature like laryngospasm can occur while the endotracheal tube is there. How and when it can happen? Anyone, please. Sarish, tell.
Sir, when you overfill the ETT cuff, does it happen at that?
No. Overfill ETT cuff, what will it do? It will press outside. It is not from inside. ETT pressure are low pressure. So how can it block the endotracheal tube? If the endotracheal tube is kinked, totally kinked and blocked. Okay. So, and the scenario will be that the patient is in light plane. Okay. So patient is having effort of this patient effort is there, and the tube is kinked, or patient has bitten the tube. Okay. Or even for example, if LMA is there, if the patient has bitten the LMA and it is the area is totally blocked, then there will be the similar feature as occurring in negative pressure pulmonary edema. Okay. Because the patient is having effort, patient is trying to, if just because this is a question which is repeatedly asked in OSCE exams for you people. So how a negative pressure pulmonary edema develops, Sarish?
Sir, by all these methods that you have just told us.
No. This is the cause. What happens? How pulmonary edema occurs?
Pulmonary edema, basically, sir, pulmonary edema is related to right ventricular pressure.
Negative intrathoracic pressure.
Negative intrathoracic pressure. How? So I give you a statement. There are more chances of developing negative pressure pulmonary edema in Zishan than Dr. Nadeem. What will be the reason? Actually, it is more so in muscular people. And how it develops? It is the negative pressure which is being generated inside the thoracic cavity. Okay. Usually what is happening? There is air is coming out. How negative pressure ventilation occurs? What is difference between positive pressure ventilation versus negative pressure ventilation? What is difference? Because if you don't understand this thing, you can never understand negative pressure pulmonary edema.
Sir, in a normal awake person, we create a negative pressure. We expand our chest and diaphragm.
Yes, the diaphragm.
Diaphragm
is the main thing which is pulling, which is going down, contracting, and there is a negative pressure which is being generated, and the air is sucked in. Okay. Air is sucking in. Okay. So this is what happens.
Yes.
So if there is some blockage in between, so the lung, this one diaphragm is keep on contracting and creating a negative pressure, and no air is coming. So only the poor vessels are there. Okay, which are tiny vessels in the pulmonary tree, and the fluid is coming out as a suction. Okay.
Actually, the suction is not exactly at that time. When the negative pressure, when there is obstruction and there is negative pressure, the capillary walls are disrupted. And when the obstruction is relieved, at that time, when the venous blood is coming with pressure, at that time, the fluid comes out of the vessel.
You are absolutely right. But actually, both things come, you know, it occurs quickly. It occurs very quickly. Rupture will result in fluid extravasation. Okay. So yes. If it is exactly written like that, I'm not sure, but I have the concept like this. Okay. So because when so much negative pressure is generated, so yes, capillary rupture also occur, and actually out of the pressure difference, fluid is coming out because there is nothing else over there. So the left thing is only the fluid, the blood. So the fluid is coming out, and yes, this reason is also there. So now you understand it is not the normal mechanism of pulmonary edema. That is something else. That is because of failure of the heart. This is not, this is totally different. Okay. So this is something which is maybe a result of hypoxia, and so if you just move further, there will be one reason for hypoxia is bronchospasm. Okay, so bronchospasm, if it is too severe, maybe there is no air entry. You are feeling no air entry. Not necessarily you are feeling wheeze, and it will be evident as increased plateau pressure or peak airway pressures.
Peak airway pressure.
Airway pressure.
Peak airway pressure, peak inspiratory pressures. Okay, and it is showing the dynamic compliance. Dynamic compliance. Okay, so what you will be doing, you will be, of course, you will be ruling out any inadequate anesthesia, analgesia, muscle relaxation. In addition to that, you can increase the inhalational agents. Okay, because this will be the first thing you can do, because if the patient is like, so first thing you will be doing this thing, and then you can do some beta 2 agonist. You will be giving, okay, through the endotracheal tube, and you need to give quite number of puff. Okay. At the same time, if you are talking about bronchospasm, please, if you don't forget, please always mention that you have to rule out hemodynamic collapse along with bronchospasm, because it may be a sign of anaphylaxis. Okay. So when you are talking about this thing, you do tell. Okay. And maybe you are giving some medication which may be a trigger, like maybe NSAID is one of the trigger. Okay. Antibiotic, of course, with the this one, there may be some blood transfusion going on. Okay. Because there will be some reason in addition to the traditional patient with COPD or asthma. Okay. Or this one, light plane of anesthesia. Okay. As we was saying something else, any histamine releasing medication. Okay. What else can be the reason of bronchospasm? This secretion. I'm sorry?
Hypothermia?
Hypothermia can cause bronchospasm? I'm not sure. No. Hypothermia, how will it cause bronchospasm?
Sir, once my patient had this and my consultant told me that you did not turn off the
Remember
AC
one
for a
thing.
week.
Remember one thing. If Dr. Sayyid Ishan Javed Hashmi, whom you people respect a lot, even if he's saying something wrong,
Yes.
please never quote me. I beg you. Because this is not a reference that X, Y, Z. If, for example, you respect your father or mother, if your father or mother who is non-technical tell you that hypothermia can cause bronchospasm, will you respect them?
No, sir.
Thank you very much. Respect the concept, not the people. Okay. Unfortunately, we respect our people only. We don't use our brain. We keep our brain at home. That's why we are not able to understand anything. If you use your brain, I can guarantee you can think much better than anyone else. Okay. So it's like that. Okay. So what else? What else may be the reason of hypoxia? Now if you go to the gaseous exchange, okay. So gaseous exchange, of course, there may be some, again, coming back to any patient factor. Surgical factor. What may be the surgical factor of hypoxia?
Iatrogenic pneumothorax.
Pneumothorax. Okay. Very good.
Retraction.
Retraction
or pressure on diaphragm or lungs.
You are missing a very simple miskin thing. Vagal.
Positioning, sir.
Vagal stimulation.
Vagal stimulation. Okay. Vagal stimulation can cause bronchoconstriction.
Yes.
Okay. So when you go to bigger thing, you forget the simple thing. Okay. So of course, positioning. We discuss so much positioning, maybe a cause of hypoxia. Okay. What else? Now you can see anything. Fluid overload. Okay. And now hypothermia, you can say. Hypothermia will cause hypoxia, not bronchospasm. Okay. Hypothermia can cause hypoxia. How? Or you can, there will be another reason, not true hypoxia, because of SpO2 error.
Yes. Cold periphery.
Okay, cold periphery. Circulation is not there. And now we will, because we are just almost concluding, we have covered a number of things. So in addition to any other respiratory gas exchange problem, okay, CVS problem, a theater environment like this cold, and then pulse oximeter errors. Okay. By the way, what is the working principle of pulse oximeter? There are two things, because this is very important when you are using it. What is the working principle of pulse oximeter?
Spectroscopy.
Beer Lambert.
I'm sorry. Yes, Dr. Nadeem.
Beer Lambert.
Beer Lambert is for what? Beer Lambert is for oximetry. Okay. So basically there are two components. One is oximetry and one is plethysmography. Okay. Plethysmography is the pulsatile flow of the blood. And oximetry is telling you about this Beer law and Lambert law. Okay, so it is telling that about the different different type of hemoglobin absorbing different wavelengths. Okay, and Beer law, Lambert law actually is something else. It is related to path length, and it is for the concentration. Okay, so it is not really for only for oximetry. Actually, it is the difference in the absorption pattern of oxyhemoglobin and deoxyhemoglobin. Okay, so Beer law is that if there's some concentration of something is more, there will be more absorption, and if, for example, the path length is more, it is absorbing more. So Beer-Lambert law actually has very less involvement in pulse oximetry, and we are always thinking about it. So you should be very clear about this is the absorption of oxy versus deoxy. So you should be knowing the wavelengths. And then the important thing when you are having the differential diagnosis of hypoxia, remember one thing: if the graph is not coming regular, okay, you cannot trust on the saturation. Okay, because it will not be correct. So don't trust, even if it is 100%, even if it is less. So the graph should be correct to have the accurate saturation reading. This is another important thing. Okay, so there may be errors in as in CO2, as in different hemoglobin, and as in cyanide poisoning, or there are so many things. You should be knowing HINA. Okay, different people will have different issues. So this you should be ruling out whenever you are targeting a thing. In addition to what we discussed, ABC, 100% oxygen, checking circuit, checking tube, checking position, checking everything. This question, which I have, this topic which I have discussed, will be asked to you in different ways. They can ask you about laryngospasm management. They can ask you about bronchospasm management. They can ask you about, because we have touched a number of things. Bronchospasm, of course, if you feel this, you are doing ABC, and then you are giving inhalational agents, and then you give some beta agonist, and you just try to rule out any cause, and then you will be, next step will be, if it is all failing, then you can go for further things. Like, for example, you can use traditionally it is written in the books aminophylline. Now it is not in the guidelines, but you can think about it. You can use magnesium sulfate, and like according to the scenario, there will be different things. And laryngospasm, if it occurs, you will be starting from ABC. Again, you will try to give the stimulation in the Larson point, this laryngospasm point. You will try to give CPAP, fail, lidocaine, fail, propofol, fail, propofol with low dose of suxamethonium, fail, full dose of propofol and suxamethonium, and intubate, give PEEP, give ventilation, and that's it. No role of steroids, no role of antibiotic, only you are giving, ventilating the patient. And then the next step will be, according you, if the blood pressure is not maintained, you will be giving some support to the blood pressure, and then you will be diuresing the patient, prop up and ventilation. That's it. That's a stepwise approach for laryngospasm, and other things we have seen discussed. Okay, so anything else you can add? Any other thing which can be there? If I'm missing, you will correlate with the blood pressure, heart rate, arrhythmias, circulation thing, and then you will correlate with the SpO2 reading, end-tidal CO2, physical observation, and what else? Anything else in hypoxia? Before, actually, we discussed the different types of hypoxia. One is anemic hypoxia. One is hypoxic hypoxia. One is cytotoxic. Okay, so these are different things which may be there, and there will be some history about it. So I hope we have covered this topic. Any question about it? Any comments? Anything?
Negative pressure pulmonary edema. The maximum how much is the maximum pressure generated?
There is no fixed value. Zishan, just help me out because I don't have the answer. If you have read about it,
I don't
I think
remember,
it is
sir.
35
I've
to
read
40.
about it.
Even negative. Normally, what maximum normally how much pressure is generated? It is usually around I think 10 to 15.
Minus 6 to 8.
I'm sorry. Yes, around 10 to 15. Okay. So I think definitely it will be two times at least more than that. But I don't think so. It is a very significant thing, Dr. Nadeem. It is increasing, and it will be because a young muscular patient will be developing more negative pressure than an old man. Okay. So that will be a difference. And then again, there will be certain factors for it. If patient has limited cardiac reserve, that patient will be suffering more. So there are so many factors, other factors, which will be augmenting it. Okay. But this is one of the most common thing which you face. Hypoxia in intraoperative period, hypoxia with, we can just say a few words that if, for example, if you are giving a neuroaxial block, central neuroaxial block, and it is going beyond, for example, the level, it is becoming high spinal. There is involvement of the intercostal muscles, so it can result in hypoxia. Okay, positioning related we discussed, but it will be augmented if you have given a spinal, and now you have patient is a lithotomy or and patient is a little Trendelenburg, so the problem will be augmented. Okay, so another thing will be that this one, if it becomes total spinal, then you need to ventilate the patient and you need to wait for the diaphragmatic function to be recovered. Okay, high spinal, if maybe patient become apneic and you may need to control the airway, but the thing will be that if you correct the hypoxia, it will reverse quickly. It will not be like total spinal, because in total spinal, actually till the time bupivacaine is not coming out of is not metabolized and the duration of action is not finished, patient will not be able to breathe because the cervical segment is involved and now there is no function with the diaphragm. So that is the difference between high spinal and total spinal. Okay. So again, patient factor, surgical factor, anesthetic factors. You have given overdose of opioids or overdose of benzodiazepine, overdose of inhalational agents. Patient is not fully recovered. The recurization, all that will be resulting in hypoxia with hypoventilation and hypercarbia. The picture may be different. Okay. So like according to if you just remember this thing, patient factor, anesthetic factor, surgical factor, if you are asked this question in whatever way, because they may be asking that in a post-operative period, patient is getting hypoxic, what is the differential diagnosis, how will you manage it? This question may be asked. And if you have a good approach, even this discussion will help you a lot in your patient care. Okay. So thank you very much. And inshallah, we will continue tomorrow.